Hello, hello, hello. Can you all see me and hear me? I guess I don't know. We're gonna give this a couple more minutes. A bunch of people are already logging in, so that's great. We're gonna talk tonight about Oncofertility. So give it a few more minutes. And I'm gonna just check out. So, nice to see all of you tonight. My name is Kristen Kane. I'm a fertility doctor at Kindbody, and I'm here to share a little information about Oncofertility, which is a crossroads between oncology or cancer treatment and fertility treatment or reproductive endocrinology. So this is kind of a new word. It was coined only a few years ago by a doctor who saw the need to bring these two fields together. But I've been working in oncofertility for a long time. And why do we need this new combination of these two things that seem kind of different from each other? Well, the thing is, when people get cancer nowadays, they're probably going to live. You know, we have a lot of people surviving their cancers. Cancer survivorship is much better than it ever has been before. And in the past, we used to think about only about getting people to the point where the cancer was gone and not really worrying too much about what comes after. So as our friends in oncology have gotten better and better at what they do, more and more people are getting through their cancer, doing great, and now they're ready to think, well, what's next? What else can I do? How is this going to affect the rest of my life? Am I going to be able to have a partner? Am I going to have trouble having sex? Am I going to have trouble having kids? Those things that I want to do with my life and with my future, how am I going to do those things? Is that going to be a problem? So first, I'd like to talk a little bit about how cancer affects fertility. So cancer gets treated in basically three different ways. So one is surgery, which is removal of the cancer tissue. And in the case of GYN cancers, that could mean removal of the uterus, the tubes, the ovaries, and those can really affect, your ability to get pregnant if that's part of the treatment plan. With testicular or prostate cancer, it can involve removing the testis, one or both of them, or part of the prostate or all of it. And these can all affect sexual function or production of eggs and sperm or production of hormones, depending on what is done. Another treatment, the second one, is radiation. Radiation can cause local scarring and damage to tissue that can be permanent. And then the last modality for cancer treatment is chemotherapy. And chemo, depending on what kind of chemo we're talking about, can be very toxic to eggs and sperm, particularly because they're very, very sensitive to chemotherapy, especially sperm. And these problems may not be reversible. So, the last thing that can happen with cancer treatment is because you're so busy, getting your cancer treated, it may cause a delay in your fertility plans. You may have to wait a while after breast cancer, taking this medication called tamoxifen for maybe 5 years to keep the cancer from coming back. And by the time, that 5 years has passed, maybe, that ship has sailed. Maybe your eggs are not young enough now to allow you to get pregnant easily. So, how do we preserve fertility in these patients? Well, we can freeze sperm in men. And with men, what we do is we want to meet them as quickly as we can after the cancer diagnosis, because the name of the game with guys is to get as much sperm in the freezer as possible. And so what a guy will do when they come in to learn about their fertility preservation before their cancer treatment is we're going to have a conversation, and we're going to talk about the quality of sperm and whether the sperm is able to be used for insemination, which is putting sperm up inside the uterus when the woman is ovulating. You need a lot of sperm for that. Or whether the sperm is better used for in vitro fertilization, where the eggs are actually removed from a woman's body and just one sperm is injected into each egg. And we don't need very much sperm for that. So we talk about, depending on how much sperm we get, what are your treatment options using this sperm after we've collected it and after your cancer is gone. Another thing that we're going to want to talk about is how many kids do you want to have? The more kids you want to have, the more sperm we're going to want to freeze. And then the last thing we need to know is how much time do you have before you begin your treatment that we can use to collect sperm. So some guys come over and see me and they're going right from my office to the chemo suite. They're just, we got to get this done, and we might only have time to collect one sample of sperm. Other guys may have a week or two heads up, and they can come in multiple times and collect sperm. So time can limit this, desire can limit this, and another thing that can limit sperm freezing in men is cost, because the more sperm vials you freeze and the more times you do it, the more it can add up. Women, it's a little different. So women, we need to freeze eggs or embryos, and that's a more complicated process. So we're talking the start of an in vitro cycle. So we usually start this process at the beginning of the menstrual cycle, but in cancer, we'll just start whenever. If a woman comes over and wants to freeze her eggs, then we do need 2 weeks to give her the medications, to get the eggs to ripen up and frozen. But we have discovered with our cancer patients that we can pretty much start the process whenever we want to in the cycle. And as long as we're not trying to get her pregnant that cycle, we'll get some eggs. So that is something that we can offer is almost immediate start to the treatment. Another thing is it's possible with egg freezing cycles to do them back to back. So say, you've been told you need to undergo some treatment, you want to freeze some eggs. We do the 2 weeks of meds, we harvest the eggs. We can start up with medication again in just a few days after the egg retrieval and do another retrieval 2 weeks from then. So if we have time to do that, that's a possibility. Another thing that we worry about a little bit with egg freezing or embryo freezing, these fertility meds increase the levels of hormones in the body, especially estrogen. And there are certain cancers that grow in response to estrogen. So those cancers are things like ovarian cancer, uterine cancer, breast cancer. So for those patients, if we're doing any sort of egg retrieval, we want to keep the estrogen levels as low as possible, but we have the capability to do that and still get a lot of eggs. We use medications that artificially lower the estrogen that's produced by the body. And we always consult with your cancer doctor about what their recommendations are and what things they're comfortable with and what things they're not. So what's the difference between egg freezing to preserve your fertility and embryo freezing? There are a couple of differences. One is embryo freezing is getting the eggs retrieved and then fertilizing them with sperm. So usually this is done in people who are partnered, who have a long-term partner. They want to make sure they can have a baby with that partner. They may want to do testing of the fertilized eggs or embryos to see if we can tell if a cancer gene is being passed on. There may be some worry in certain types of cancer about chromosome abnormalities, and so they may want to do testing for chromosomes. So freezing embryos allows that, but it's more expensive, and you're committed to the person who gave you the sperm to fertilize the embryos. So egg freezing gives you more flexibility. The eggs can be stored, and embryos, 55 years they just said. So that's pretty good. You can hold them onto them for a really long time. So egg freezing, you go through the IVF cycle where you take fertility medications by injection for about 2 weeks. You do have a lot of visits, maybe 4 to 6 visits for ultrasound so we can check the growth of the eggs, and blood work so we can decide if we need to change the dose of the medication. And then when the eggs are retrieved, they're frozen and you're done. You can get started with your cancer treatment very quickly after that. So basically, we want to do this as soon as we can. So one of the reasons that I'm doing IG Live on this topic is to also share with other doctors who are friends of mine on Instagram that may run across cancer patients. Look, we're out here, and this is something important that we can do, and really help people have a great life and achieve their dreams after they're done with this chapter of taking care of themselves and dealing with cancer. So we want you in as soon as we can. And then the cost of this, is something I'll just talk about really quickly. So on average in America, an egg freezing cycle, including the medications, this is just freezing eggs, is about $14,000. Our fees at Kindbody are less than that, and you can look them up on our website. They don't include the medications, which would probably be an additional $3,000 to $4,000 for the medications. Sperm freezing varies from clinic to clinic. It may be hundreds, it may be low thousands. It is cheaper to do because it's easier to get sperm than it is to get eggs. Embryo freezing is more because we have more to do with the eggs. So we have to, in the lab, take the eggs and fertilize them with the sperm. We have to grow them and take care of them in the lab. We may want to do chromosome or genetic testing on the fertilized eggs. And then we have to, do all that. So in general, on average in the United States, an embryo freezing cycle is $20,000, and that includes the meds. And it's probably $4,000 to $6,000 additional to check the fertilized eggs for genetic or chromosome issues. So those are things that are kind of like, whoa, I'm already not working. I'm already spending all this money on my cancer treatments, and I need extra help at home because I don't feel good. What am I going to do? This is really expensive. So I'm getting a little ahead of myself, but I'm just going to go there. As far as dealing with the costs, most fertility practices do have some sort of help for you. And not only that, most drug companies that provide the fertility drugs also have what they call compassionate care programs. And the fertility clinics know who's got those programs at any given time. The final thing is it's possible to get grants to cover your fertility preservation in cancer. And really, I was going to give you the names of some places you can do that, but I went online and looked to give you some names, and there's so many. It's very easy to find places that do grants. Your oncologist may know of some places that have been good for grants, or your local reproductive doctor may also be aware of some grants locally that you can use. So let's talk a little bit. I'm going to go back to the more medicine part. Let's talk a little bit about chemotherapy. So chemotherapy kind of breaks down into 3 groups. The high-risk agents that are really, really toxic to eggs and sperm. In particular, those are the alkylating agents. So things like cyclophosphamide is very toxic. It's dose related. There are some others. These are really good chemotherapy agents. They work great, but they can do a number on your fertility. Lower risk are the agents like taxanes, platinum, anthracyclines. You may have permanent sterility from those agents, or you might have a decrease in your fertility but still have some fertility, or you might bounce back. The younger you are when you get treated for cancer, the more likely you are to bounce back and have good fertility later on. So that's also reassuring. And then the lowest risk agents are things like methotrexate, 5-fluorouracil, vincristine, bleomycin, actinomycin. And then there are some new agents called tyrosine kinase inhibitors that we really don't know a lot about yet in terms of the fertility effects. As far as radiation goes, again, age matters, younger is better, and the dose matters and the location matters. So abdomen and pelvis is, an issue for women who are trying to get pregnant or men who want to father a pregnancy. But interestingly, head and total body radiation also can have effect, because in your brain there's a gland called the pituitary gland, and it makes these hormones that stimulate your ovaries or your testes to produce sperm and ripen up eggs and produce hormones. And if there's damage to that area of the brain, it may not produce those hormones as well, and your body may not be able to respond as well to do those things. It's important also to realize, as I said before, the testis is very, very sensitive to radiation. So the dose for kids is like, I want to say 100 times more that's safe than the toxic dose for testis. So that's really interesting to know. It doesn't take a lot of radiation to affect the sperm. So if radiation is in the cancer treatment plan, very, very important to freeze some sperm as much as we can. So who should be referred? Who should be seen by a fertility doctor before they start their cancer treatment? Pretty much everyone who's reproductive age, meaning anywhere from the teens to the 40s, and is going to be probably cured for their cancer, is reasonable to come see us. Anyone who has questions, we'll see you. That's what we're here for. You may not decide you want to do this. You may just be wondering what it's all about or if this is right for you. You can come see us. And then so at the initial consult, what happens to women is, we visit with you, we take a history, we ask your family plans, we ask you about your partner if you have one, your medical history, your OB history, your GYN history, if you've had any fertility in the past or infertility in the past. We may do a physical exam. We'll probably want to do an ultrasound to count the eggs in the ovaries and just kind of look at where things are. And there are some basic labs that we'll need to do. So we'll need to do a test called anti-Müllerian hormone, which is a test that is kind of like a gas gauge to measure how much juice there is in your ovaries right now. It kind of gives us a sense of how many eggs are there, how many eggs are available, and it's a scale. So an AMH in our office, it varies a little bit around the country, but an AMH in our office between 1 and 6 is normal. That's a normal ovarian reserve. If it's over 6, that's an elevated ovarian reserve, and that's great because those people have more eggs and may have a little bit more to work with down the road, may even rebound a little bit better. If it's below 1, that's a low ovarian reserve. Those patients are at high risk of losing their ovarian function after cancer treatment. So it's really important for us to do whatever we can to save what we're able to save. Then we're also going to do infectious disease tests because these eggs are going to be stored for a long time in storage tanks with other people's eggs. So we kind of store like with like. So if everybody's negative for all the STDs that we test for, the infectious disease, then they can all go together in one tank. If somebody's positive for hepatitis, they go in the hepatitis tank with the other tissue that's hepatitis positive. So we need to do those tests. For men, we'll likewise do a history And we'll want to do a sperm test right away at that visit and freeze at that visit if that's what you want to do. And the sperm test will give us an idea what we are working with, and then the freeze will know how many vials we were able to freeze and whether they're suitable for IUI or IVF. And then, like the women, we'll want to do infectious disease tests for storage. Some of these labs are definitely covered by insurance. I'm seeing a question pop up. I might be missing some questions, so I'm sorry if I am. But yes, a lot of these labs are covered by insurance because it's just blood work. So it's pretty basic, and if your insurance covers testing, it does. And if it doesn't, you can talk to your fertility doctor about what the exact costs would be and if there's any way to, lower those costs. What we don't recommend is we don't recommend choosing your cancer treatment based on the fertility effects. You need to choose your cancer treatment based on what's going to get rid of your cancer. So we don't recommend, I would definitely tell your oncologist if you want to have children down the road or you want to, preserve your fertility, and let them figure out what the best thing is for you, keeping that in mind. But this isn't a place where you go on Dr. Google and you look up, taxanes and you say, I want this one instead of that one because it's really complicated. I don't go there. I don't know anything about chemotherapy. You heard everything I know. So we don't recommend doing that. The other thing is we don't recommend delaying your treatment excessively. So there may be a need to delay treatment a little bit, a week or two, a couple of weeks, for women who are going through chemotherapy or surgery or whatever. But we really don't recommend excessive delays of treatment. You need to be here to have the baby. So we got to make, cancer's the priority. We got to make sure that's taken care of. One of the cancers that's kind of a unique situation is ovarian cancer. So I wanted to talk about that a little bit because there's a risk if we do in vitro or egg freezing and we go in and retrieve the eggs with a needle that goes into the ovary, there may be a risk of taking some of those cancer cells out and seeding them in other parts of the body. So that would increase the stage of the cancer and make the cancer worse. So that's one thing that we have to be really mindful of, and we don't automatically just go and do this in ovarian cancers for that reason. There's also a risk of reseeding cancer with the eggs or with ovarian tissue, which can also be removed. Just remove the ovary and then go through the tissue on the ovary, and they slice it up really fine. And we check the tissue under the microscope to see what parts have cancer cells in them that we can see and what parts don't. And the good stuff gets frozen, and that can maybe be used for future use and even reimplanted in the body. But that, we have to be careful with that because it's still somewhat experimental. Only, not every place does that. Not every place has the really skilled GYN oncologists and pathologists and egg freezing embryologists or ovarian tissue freezing embryologists to do this very specific thing. It's still somewhat kind of new, but it is possible if you have somebody who needs who has ovarian cancer or another kind of cancer and needs treatment now, does not have time to do IVF. It's possible to take the ovary and freeze it, and without stimulating or taking any fertility meds at all. And this is great for people who are children, who are young teens, or people who don't have a lot of time before they start their treatment. So this is an option for those kids. Another thing that we can do to protect the ovaries in cases of radiation to the pelvis is we can do something called transposition, where the ovaries are kind of lifted up and kind of tacked out of the range of the x-ray so that the radiation doesn't hit them quite so hard. Basically, so how well does this stuff work? Well, if we're freezing sperm, what are the pregnancy rates? What are the odds you're going to have a baby with this sperm that you've frozen? Well, if we're doing insemination, the cumulative pregnancy rate for men who use insemination with their frozen sperm is 36%. And with IVF, 50% is the cumulative pregnancy rate. Now, these numbers might be a little old. The IUI pregnancy rates probably haven't increased a lot. IVF pregnancy rates go up all the time. We constantly, every year, are seeing improvements in our IVF pregnancy rates. We're coming up with more and more ideas how to maximize that for people. And it's possible also to do a biopsy of the testicle and take a little bit of tissue out and freeze that with sperm in it. And that can be done in boys as young as 12. Under the age of 12 or under, early puberty, there really isn't sperm there for us to get. So we would have to worry about different things. But they're also, because they're inactive, more likely to not be as affected and have some fertility afterwards. And then one of the things, before I wrap it up here and start answering any other questions you might have, is, and I forgot where I was going to go. Oh, well, it'll come to me. Basically, what I want to just summarize with is that cancer is diagnosed, ask for a referral to a fertility doctor, to an REI. Ask your doctor to send you somewhere. Most of us, will do whatever we can to get you in right away. This is not a situation where you're going to have to wait 8 weeks or 5 months or whatever for an appointment. We will do what we need to do to get you in right away. We all understand how urgent this is. That the fertility doctor needs to be comfortable with Oncofertility, able to accommodate last minute appointments. Most of us are, not everybody is. And ask for compassionate care packages. See what you can find. And then I wanted to talk a little bit about advocacy groups because we're trying to change state laws around the country. And a lot of us in different states are working with our local peeps to, boots on the ground, trying to figure out what's going on, what laws are going through the legislature, and trying to write our own bills to mandate fertility, preservation, in cancer patients, among other things. We advocate for lots of things. But if you want to, this can be very healing to know that you're doing something like this to help other people in your shoes. When you're feeling better, of course. This is something you can do. You can just Google your state and fertility preservation advocacy. You'll find groups. You'll find them on Facebook. You'll find them all over the place. You'll find them on Instagram. There are there's a couple different types of advocacy. One is, trying to actually change the laws to cover fertility treatment. And then in the short term, there are a lot of groups who are focused on covering costs. And those groups need help and support as well. So if you want to support them in any way, whether it's sharing information on social media or donating money or working with them, these are all really great options. Another thing I just wanted to go over is once you've survived, there are other things that we need to think about in terms of your fertility and reproduction. So you need to make sure you keep up with your planned cancer screenings for other things. So if you had, say, cancer of the cervix, well, you still need to make sure you're up on top of your colon cancer screenings and breast cancer screenings and all of that. If you've had cancer treatment, your fertility may decline, but it's not a given that you can't get pregnant or father a pregnancy. And shortly after you've been treated, your eggs and sperm might not be their best. So you should make sure that you have some kind of birth control, that is being addressed with you, that you're not getting pregnant by accident on medications that aren't really good for you to get pregnant. If you haven't had the HPV vaccine, which is a 3-shot series that protects against cancer of the cervix and the throat and the mouth, be sure you get that. And after cancer treatment, it's possible to have drops in your hormones. Women can go through menopause at an earlier age and have hormonal insufficiency and may need hormone replacement therapy. Men, unless they've had really hardcore radiation or actually removal of the gonads, typically will have a rebound of their hormone production and be pretty good and have pretty normal sexual function. But it's possible that those could be affected as well. So it's important to know that that's common and to be prepared to be treated for that. And if you have questions, I'm happy to answer them if you want to, type anything in. I'm located, where am I located? So Kindbody is all over the place. I personally am located in Atlanta, but we have Kindbodies in Los Altos, San Francisco, Los Angeles, Santa Monica, Century City, Princeton, New Jersey, a couple in New York City. We have one in Austin, one in Orlando. We're opening one in Minneapolis. We're opening one in Denver, which just started. And we're just going. So we're all over the place. And any other questions? I think if we don't have any other questions, we can call this good. Thanks for listening. Thanks for joining me tonight. It was great talking to you, and hope to see you soon for normal stuff. But if you need our help, we're here for you. Bye-bye.